Well, thank you for that introduction and making a spot for this particular disease. It's my pleasure to be here. It's my first time here, and nice to meet all of you. I'm going to focus a good portion of my talk into just the curative portion. These are my disclosure, and there's some medications here that are being used offline. And the objectives here are sort of in 4 parts. About medications. We'll talk a little bit about match-related donor stem cell transplant, loop into haplotransplants, and then finishing up with gene therapy, as some of you have heard being referred to. It's well known to this audience that sickle cell disease is a genetic mutation, and when you have that particular mutation, it causes a change in the amino acid of the beta globin gene that carries the oxygen, and that causes the red cell to change from the characteristic, the donut shape to the crescent shape. And there are acute and chronic manifestations of sickle disease. We're all very familiar with the hemolytic anemia, and also with the very frequent pain crises many of you have taken care of. Here in North America and in Europe, we admit most patients with pain crises because in about 10% of the patients, that pain crisis can turn into acute chest syndrome, which is the #1 mortality cause. And as you can see on the left here, sickle cell is a chronic disease that affects pretty much every organ from top to bottom. And I have highlighted just a few, like the brain, the liver, the heart, and potentially priapism that could be reversed by hematopoietic stem cell transplant, whether it be allogeneic or gene therapy. This is a brief view of the current treatment and upcoming treatments. We have obviously the medication treatment with some that are recently approved. You'll hear just a little bit more about the updates in the allogeneic space. Also in the ex vivo gene therapy, where the person's stem cell is being mobilized and apply gene modification. But what's coming in the future is to mirror a little bit of that of in the hemophilia gene therapy, where this could be delivered in vivo. The approved medications now, you guys know very well with hydroxyurea. It is really the only one that has the disease-modifying capability. It reactivates fetal hemoglobin, and it reduces white blood cells because it has myelosuppressive activities. And the goal is to increase fetal hemoglobin, and with that, the total hemoglobin level can be also increased. There are a few others that were recently approved. One of those is L-glutamine, or Endari. Rather than a pill, it comes in packets, and patients have to take several packets per day. It has antioxidant-like properties and is said to prolong red cell survival. But as the antioxidant property tells you, it really has no change in the hemolytic or the CBC parameter. The voxelotor, unfortunately, that was just recently taken off the market. It increases the oxygen binding capacity of hemoglobin so that it hangs onto the oxygen a little longer. And with that, the sickle hemoglobin doesn't polymerize as much. That does lead to a slightly increase in higher hemoglobin, but recently it was taken off the market because in several of the African centers, several patients actually died on this medication, and some of those reasons for death were from malaria. The relationship between malaria and taking the voxelotor is unknown, but Pfizer preemptively took the medication off the market. Crizanlizumab, it's an IV infusion. It starts with twice a month, and then the maintenance is once a month. It's a p-selectin inhibitor. It reduces red cells and platelets from adhering to vessel endothelium. And again, it doesn't really change any blood or hemolytic parameters, but it can reduce the painful crises. However, in Europe, this actually has been taken off market because in many treatment centers, it just doesn't seem to work as well. The newest kid on the block, although it's not approved for sickle disease, but approved for pyruvate kinase deficiency, is mitapivat. It has recent indication emerging in beta thalassemia, as you've heard, but it's also being used for sickle disease. And being a pyruvate kinase activator, it actually provides extra ATP, again, to prolong red cell survival. And we know in our centers and multi-center phase 3 trials that it leads patients to have not only lower rates of hemolysis, but also increases hemoglobin. And then there are several other anti-sickling medications at various stages of preclinical and some in clinical trials. So I put this here just so that you can see the comparison of the different treatments, sort of side by side. On the left side here, you have just a typical sickle patient, not on any treatment, where the S percentage on hemoglobin electrophoresis is about 90%. The fetal hemoglobin is expectedly low, could be 1 or 2% or so, and their hemoglobin is running between 6 or 7 grams per deciliter. On hydroxyurea, the fetal hemoglobin is nice and high in that 20 to 30% range. And the hemoglobin can rise, 7, 8, and I have a few patients up in the 10 grams per deciliter. And as you can see on the, for the newer therapies, they really don't change the hemolytic parameters. And with the Endari or the L-glutamine or the crizanlizumab, rather than having pretty good effect in reducing hospital admission rates for pain crises, those two medications only has a modest effect. And for many hematologists, such as yourself, you probably think that it doesn't work as well, so you don't prescribe it as well. And so we see many patients in consultation. We always tell the referring physician or the patient themselves, when you can, try to get them back on hydroxyurea, and try to get them on a good therapeutic dose of hydroxyurea, and that's somewhere between 15 milligrams or even 20 milligrams per kg. And that translates to about 3 tablets of the 500 milligrams of hydroxy. Now I want to switch gear just a little bit to talk about curative treatments. The first up is the match-related donor stem cell transplants. This first came to being close to 40 years ago now, where a patient with acute leukemia and sickle disease were cured with a leukemia type of conditioning transplant. And that it was with myeloablative intent because you want to get rid of leukemia too. And with a high intensity approach, of course, you want to aim for full replacement of the marrow by donor cells. And during the process of these ablative transplants, we learned that as low as 10% donor chimerism is still enough to cure the sickle disease. So that kind of gave rise to, what about older patients or those with an end organ injury? Are there a sort of mild or general approach? And the answer is yes. You could go with a sort of non-ablative or a more general approach using less chemotherapy or antibody-based. And you can achieve mixed chimerism in most of those patients and still get control of the sickle disease. So I just give you an example of two. One is the typical high-dose approach where they get 4 days of busulfan, 4 days of cyclophosphamide, and 4 days of that rapid ATG with a manipulated bone marrow infusion. And then you have a low-dose intensity approach using just 5 days of Campath, a pretty low dose of total body radiation, and then giving the peripheral blood stem cell that's mobilized by filgrastim. And when you compare them side by side, the overall survival is actually pretty good, in the non-ablative versus the ablative regimen. Not surprisingly, when you use a lower intensity, you have a little bit more graft failure. But that does come at a benefit of not having a lot of graft versus host disease, and also has less viral reactivation and other organ complication. So really comparing ablative and non-ablative, for the younger patient, I think many centers will opt for an ablative approach. But if you want to see the patients, or if you have a patient that is a little older meaning in their 30s or even 40s, you can consider them for a non-ablative approach, or those are coming to you already with some organ compromise. So now I'll switch gear to the haplotransplant. You heard that experts here in the room, from Hopkins, they really have revolutionized the haplotransplant by using this post-transplant cyclophosphamide. And we, like many others among the sickle space, got really excited with using post-transplant cyclophosphamide to offer haploidentical transplant. And because only about 20% of the patients can have match-related donor transplant option. And so you can sort of, I guess, categorize them in two different, groups. There are the post-transplant cyclophosphamide, where it's given after the stem cell has been infused, and that high-dose cyclophosphamide given for 2 days reduces not only the total number of donor lymphocytes, but also helps expand the regulatory T cells, which are to help to reduce graft versus host. It is moderately high intensity, but you can get sickle-free survival rate now in the upper 80%, which is pretty close to the match-related donor transplant setting. The graft versus host disease rates can be a little bit variable, but the more severe type is roughly around 10%, and you do get a little bit of that chronic graft versus host. And then there are the ex vivo T cell depletion regimens where you take the graft from the patient outside the body, and you're just selectively depleting with the alpha beta T cell, the activated T cells, or you take the CD34 cells out of them, and you get a little bit of T cell add back. And with that, even though it's not as commonly used, you can still get sickle-free survival around 80% with similarly low acute and chronic graft versus host disease rates. Here is a somewhat simplified diagram of, on the right, you have the antigen-presenting cells with an antigen that's presented to the T cell receptor of the T cells on the right, on the left. When you have this signal engaging, that's called the signal 1 of the T cell activation. And then as you can see, all the other molecules are what we call a second signal, or the co-stimulatory molecules. And at least among the haploidentical transplant, and even in the match-related donor setting, lots of different medication now are targeted towards the co-stimulatory molecules. And so over really the last 2 decades, a lot of improvements have happened in the haploidentical transplant space, and some of you have heard that already. Better supportive care, better antimicrobial prophylaxis really have reduced the transplant-related morbidity and mortality. And then with the more thoughtful design of the conditioning regimen, as I sort of have mentioned, really the survival rates, or the sickle-free survival rates, are better now. And then, because it's haplotransplant, some of the patients, either through many years of transfusions, they already develop donor-specific antibodies, and each transplant centers have their own specific protocols how to reduce that. And hopefully, with a little bit more time and more sort of data sharing, we can come up with a couple of regimens that works more or better than the others. And then the newer kids on the block are to apply co-stimulatory blockade like abatacept or belatacept that has been used in kidney transplants, and applying that in the haploidentical setting. And then I just want to finish off in the autologous gene therapy space. For many patients, when there are no suitable match-related donors, but they have disease severe enough to consider transplant, and you can kind of think of it's gene therapy or haplo. And just focusing on the gene therapy part, the gene therapy is really an umbrella term that could be gene addition, meaning you add a correct or a functional copy of the gene, and in our case, it's the beta globin gene. And so the one that was recently approved is called Lyfgenia or lovo-cel. Or you could do the gene edit, where you are modifying or changing the production of a gene. And there have been several studies that increase fetal hemoglobin production to mimic the effects of hydroxyurea. So the one that was recently approved is Casgevy or Exa-cel. And then many groups are working on the actual gene correction to fix the sickle mutation. And there are probably 1 or 2 studies that are now that's currently out in Southern California to actually enroll patients to correct the sickle mutation. So these are coming. What does the hematologic improvement look like after the gene addition? So this is from Bluebird, who was recently acquired by a larger group, where they use a lentiviral vector that adds this T87Q, which is a modified normal beta globin. Even though on this graph here, it shows that it's right next to the beta globin gene, but where it's inserted is somewhat random, and it's not necessarily next to the sickle beta globin gene. With that, you want to add just enough of the T87Q there to sort of balance out the sickle beta globin production, so to mimic more like a sickle cell trait. And as you can see here on the lower left, you can see that in the green, that's the hemoglobin S, but in the red, that's the T87Q. Really, over 9 to 12 months is when things become more stabilized. The contribution from the T87Q is roughly half to the sickle hemoglobin, really achieving similar to the sickle cell trait. And to the panel on the very right, all those dots, both the green and the blue dots, refer to the pain crises that needed to be hospitalization. After gene therapy, you can see those dots are much reduced. Similarly to the gene gene edit, the steps are a little bit different, where you target the chromosome 2, which contains the BCL11A, and you use the CRISPR-Cas9 system to cut or to inhibit the mutations in the urethral enhancer sites. What that does is it then reduces the BCL11A and then reactivate the gamma globin gene production. And again, on the bottom left, you can see that the contribution of that hemoglobin is roughly 40, and in some patients up to 50% of the total hemoglobin, where they can go up to 10 or 12 grams per deciliter. And similarly, after gene therapy, all those blue dots, which represent pain crises or hospitalization rate, it really goes down dramatically with most of the patients. So, in a patient who has severe disease, and what I mean by severe disease are patients that have very frequent pain crises, 3, 4, or more hospitalizations per year, or in that overall organ damage, the ticking off, maybe a little bit of heart failure, a little bit of pulmonary hypertension, some liver or kidney compromise. Those are the types of patients that you want to kind of refer for them to see at a transplant facility. Obviously, the first choice is the match-related transplant. It has longer history, more experience, and the side effects and the success rates are pretty well known. And then you really have pretty good regimens are well validated. The second choice is a little bit more difficult. Even though on paper, the haplo versus gene therapy seems to be pretty equal. I think when the patient starts to visit the transplant center, it's really dependent on what the transplant centers can offer. Right now, the haplo is a little bit more accessible because more transplant centers can pivot towards haplo. But hopefully through the insurance, approval process gets a little bit more streamlined. The gene therapy can be more. I do want to say one word about the sequence of the second choice. If a gene therapy is applied first and if that doesn't work, you can more easily salvage with a haplotransplant. But the reverse is not necessarily true because for gene therapy, you need to mobilize and collect enough stem cells to go through those genetic manipulation. But if you have gone through haplo already, you have already whittled that down some, and it makes the mobilization and collection process a little bit more difficult. So then this is my last slide. Just kind of want to put it together again, what the hematologic parameters look like after hydroxyurea, the best ones that we still have, on red cell exchanges, on gene therapy, and on stem cell transplant. And with that, I thank you.